folks, Scott Weingart here, and this is an EMCrit podcast. Today on the podcast, a little treat, a little confection, a little diversion from our normal intensive care type topics. There's a little bit of critical care in here, but this is my buddy Dave Carr giving tips and tricks primarily for emergency medicine. And a lot of them are general emergency medicine, not critical care. It's super fun. This is a lecture I heard at Incrementum. And as soon as I heard it, I'm like, Dave, you got to come on the show and talk about this stuff because there's some amazing tips in here. I think you're really going to enjoy it. Dave is a master lecturer. Just wonderful to get to talk to him. You're going to have a lot of fun. So strap in. Very quickly before we get in, two conferences that I really want to push. Well, I guess one conference and one an online course type. First is the Reanimate tickets. They always sell out. We've sold out every year, and we always sell out at the exact period we're about to go into. People don't buy, they don't buy, and then 3 months before the conference, we sell out tickets. And then for the next 3 months, I just get emails saying, hey, Scott, I want tickets. I'm like, no, sorry, you should have listened. This is the time to listen. This is the period right before the tickets sell out for Reanimate, our resuscitative ECMO conference. It is amazing. Every single person that comes says this is the best conference I've ever been at, aside from maybe Incrementum, but they're different kinds of conferences. And you totally want to train in resuscitative ECMO. If it's even a possibility, you could do it because it is absolutely game-changing for the management of cardiac arrest, pulmonary embolism, etc. Reanimateconference.com. And then we have the Unburnable Burnout course in September. It starts 12 sessions every 2 weeks to change people's lives. If you're even thinking about it, go to the website, unburnablecourse.com. Or you just always go to emcrit.org/stuff and find all of it. All right, let's get in. Dave Carr, tips and tricks from his career in emergency medicine. You're going to love it. David Carr, so happy to have you back on the podcast. Now, you are beloved in Canada, but friend of the show and EMCrit team member Chris Hicks has pointed out, he's called you the David Hasselhoff of emergency medicine because you are just beloved in Europe. What's the deal with that? Why do the Europeans love you, David Carr?
I really don't know. I think I've made a lot of emphasis to speak in all the countries in Europe that I can. And there's only one country south of us, and I don't speak in America so often. So it's been great to cross the Atlantic and meet doctors all over the world.
All right. Now, I heard a lecture at Incrementum #2, and it was one of my favorites of the conference because it was just jam-packed with clinical stuff, no bullshit. You have an inimitable style. You're saying, gather in, and let me tell you about all of the things I've learned. And the first slide of what you sent me is, if you like EBM, get the hell out of here. And so we're not going to be talking about studies. We're not going to be talking about numbers. Now, I kind of lied. There actually is evidence for everything Dave is saying. He wants to get away with just being the bad boy, just talking about clinical anecdotal experience and no EBM. But there is EBM, and I went back and actually put all the studies in the show notes. And there are studies for pretty much everything he talks about. So we won't talk about them during the audio, but then you go to the show notes for this episode, and you will find the studies behind pretty much everything we speak about. We're going to be talking about the tips you have learned in your fantastic clinical career, Dave. So should we roll in?
Yeah, 100%. And I think you gave the perfect introduction because this is not textbook medicine. This is kind of stuff you pick up on podcasts, stuff you pick up from colleagues who say this is the way they do it and it works. And I think there is a space for non-evidence-based tricks of the trade. And that's what I'm really excited to share it with you today.
Yeah, it's perfect. All right, so we're just gonna go through them, and then if people have questions, you put them in the comments, and we'll elaborate from there. All right, so this one was like, oh my God, why didn't I not think about this? This is so much more clever. So it's instead of making people wait for a trial avoid after removing their Foley, you have a much better way of handling it, David. So tell us about that.
Yeah, you know what? It's so funny. I think about it when I heard you talk about apneic oxygenation. It was one of these moments in my life where I'm like, why didn't I think about that? It's not that hard. It's not that clever. I could have easily done that. Why did Scott have to preach this first? This pearl, exactly what you talked about, Foley, was that to me. And that's why I want to start off with it, which is, You would typically see some 80-year-old guy who comes in with a Foley. They want to have it removed. They're pretty pissed off because their urology appointment got canceled. And they come to the emerge saying, I need to get this out. And historically, the way we would do this is you'd ask the nurse to take out the Foley, do a trial avoid, and basically flood the guy. Give them liters upon liters, and either one of two things happened. Either you put them into heart failure because they had a grade 3 LV, unbeknownst to them, or they peed, or I guess they didn't pee and you put the Foley back in. And that was a lengthy process.
Pain in the ass.
Pain in the ass. So what this nurse, Nassim, said to me, I remember I just said, just trial avoid, tell me when he pees, he can go home. He said, Dave, can I just tell you how we do it upstairs in urology? I happen to work there part-time. He said, instead of getting him to trial avoid, right before I take out his Foley, I'm going to put 300 mils of sterile saline into the bladder, and then I'm going to clamp it and then take out the catheter. So essentially, he's got a full bladder the second the Foley's removed. Then I show him where the bathroom is, and either he can pee or he can't, and I put the catheter back in. It basically takes the ED length of stay from 2 hours to 2 minutes, and he's not in congestive heart failure.
Yeah, it's just brilliant. I love it. I love it. All right, so that's tip number one. If you take nothing else, you've already gotten that. You've already won. It was already worth listening.
I think so. Totally. The next one is a great pearl, and I kind of start off with this urology flavor. I'm not sure why. It was a pearl by Catherine Varner and Connie LeBlanc, who are Canadians, and it's this concept of how do you treat priapism. And the reality about priapism is none of us really want to stick needles into the penis and start aspirating and doing all this stuff. It's kind of makes us, it's always made me uncomfortable.
Well, and the patient certainly doesn't want to hear that you're going to stick a needle in their Johnson.
Very patient-centered. No, exactly. So what they did and what they studied is a trial of lower limb exercise. So it's essentially someone with priapism, you take them to the stairwell in your emergency department in your hospital, and provided they, again, don't have significant coronary artery disease, you ask them to walk up and down the stairs for 5 to 10 minutes. And Scott, I've done this a handful of times. I have had unlimited success. It's like the patient's walking down the stairs, and already they're like, it's working, doc. I feel like it's getting better. And it's unbelievable. So they walk until the erection's gone, or they pass out or something like that. And it's magical results.
David, now I think this is a wonderful tip for emergency medicine once they hit the department, but it seems like you're really missing a role of doing the public service message for people in the community, David, that they should try this before even calling the ambulance. And I think this is a perfect role for you to be the spokesman in Canada on TV. I think this is your next move, is to really help.
I think in Europe, this is the David Hasselhoff. I've been basically encouraging priapism care. The people who actually love me most aren't the patients, it's the urology residents who no longer get called to come in at 3 a.m. to do an aspiration because it's already been done. And they're the big winners here as well.
No, that's fantastic. And most patients could be sent home with those same instructions of if this happens again. You know what to do before. And if it doesn't work, then call us and come on in.
Yeah, everyone has the stairwell.
Now, I'll just put out the proviso. Do not delay for extended periods of time doing this. This might be if you're going to let urology be handling it. You've already put out a page to urology and you're waiting for them to arrive. Or you just want to try this very quickly prior to then moving to more aggressive care. You do not want to delay, all right, we'll check back in an hour, see how that exercise worked. That's going to put you in a bad situation. So if you're going to do this, try it, see it works or doesn't work very quickly, and then move on to the more aggressive treatments. All right, now we're going to go to one I think might generate some controversy. So we'll see how you couch this. This is the palpation of the eyeballs, David.
Yeah, so I've kind of gotten to this point in my career where I was sick of making the excuses that, one, the Tonopen doesn't work, or two, I can't find the Tonopen. And I think we're all guilty of it. And it always starts when you're working up someone with glaucoma and you check the pressure in their unaffected eye and it's like 50 and you're like, oh my God, I have no idea what I'm doing because that's the good eye. And I'm not advocating that there's not a role for measuring intraocular pressure, whether you believe in POCUS, whether you do anything else. But I think it's important to know that prior to tonometry, people actually palpated globes. And if you have two eyeballs, and if you just right now on your show while you're listening to this, feel feel your eyeballs and push backwards and say, hey, you know what? When I'm pushing, they both feel the same resistance as I'm pushing across that aqueous humor. They feel the same. Well, what if you had significant eye pain, redness, nausea, and vomiting, and you pushed on both and they felt differently? That's palpation of acute angle closure glaucoma. And I think you should get comfortable to just palpate globes prior to your attempt at locating, utilizing the tonopen that you have. And if you don't have, or you're working in a center that doesn't have, at least say, listen, I don't have a tonopen, but I can tell you on palpation, there's a profound difference that I appreciate.
I think as a rule in, it makes complete sense. And would you ever rule a patient out, David?
No, but I can at least then say the tonopen's broken and you probably need to go upstairs,
there
right?
You go.
Like,
okay.
That's my rule out. I mean, look, I think if someone's that bad, you might rule in no problem. But you're absolutely right. I am not advocating the lack of tonometry. I'm advocating a basic skill that should also make you say, I better get a tonopen, and where is it? And maybe we can borrow one from upstairs.
Why is it so fucking hard? And like, I even tried the newer one, and the newer one has little plastic things that fall out if you turn them to face the floor. Like, why? Why haven't anyone created one that's ED friendly rather than ophthalmology friendly? I don't understand.
I don't know. I also know there's one person in the department who's like the best at it, and I'm always looking. It's like we have a physician assistant, and I'm like, hey, do you think you could just come and help me? I have no idea what I'm doing, because we just got that new one as well. It's intimidating, that new one, with those little things.
Yes.
And the patients can tell you don't know what you're doing. So palpation, I'm pretty convinced.
They smell fear. Yes. Yeah. All right. So I like this. I like this for, the tonopen is broken, but yes, that is a good way. All right. Now this one, the Surgicel burrito. Tell me about the utility of this, Dave.
Yeah. So I don't like epistaxis. I think we all have charts that we don't want to pick up. I think we all have things that just we don't like doing. I guess I don't like epistaxis. I never have. I think of uncomfortable things we do in emergency departments, shoving a rhino rocket or some nasal tamp. It's incredibly painful. And what always happens to me is that it bleeds a little more, and then you call ENT and they say, put a bigger one in, and then you just torture to a much higher degree. And the real annoying thing for patients is they got to come back in 48 hours to have these removed. Yeah. And they always bleed when you pull them out because they're on an oral anticoagulant and it's really dry. And despite your attempts to moisten it, you pull and they rebleed. And they've paid for parking and they waited 4 hours, and it sucks for them. The Surgicel burrito concept is you take some gel foam, which is available on that wound cart. Again, there's someone in your department who knows where that is and what's on it, probably not you. And you wrap that gel foam with Surgicel, which helps with clotting and helps to stop bleeding. And you then just insert that into the nostril. It is dramatically less painful. It doesn't need to be removed because both the gel foam and the Surgicel dissolve on their own. And usually at a point where in a couple of days it's gone, no revisit, no rebleeding, no pain. I love this technique. This is something that works really well. And I've stopped, if someone fails all the minor stuff, I've stopped shoving rockets into people's noses.
I love this so much to not have to have them come back, and then they could follow up and be someone else's problem. So do you put this in, and if it works, great, they're gone. If it doesn't work, then you're going to put in the rocket?
I think so. Yeah. I mean, I can tell you don't usually get past that step. I mean, you never know who comes back and rebleeds because you don't follow up your cases. But when I do this, if someone's got an anterior bleed and it's not posterior and not bilateral, you put this in, they stop, you send them home in 5 minutes, and you never see them again, hopefully, and you get them the follow-up or no follow-up depending on what's necessary.
Do you soak it in TXA before you shove it in?
I don't. But you know what? I probably soaked a cotton pledget in TXA prior to that and have failed that first. So I've probably either cauterized or TX or let them, whatever I've done before, I try this maneuver. It's not working. Then I go to that. So they failed that in my opinion. But that would help for sure.
All right. I like it. All right. We're transitioning to something that actually is critical care. So, don't say there's no critical care in this lecture. This is using Foley's for penetrating neck trauma.
Yeah, I had to throw something on your podcast for your critical care listeners. I don't work in a trauma center. Zone 1, Zone 2, Zone 3 were concepts I learned on an exam when I was studying, but I don't see this every day. And on Rebel EM, they introduced this concept of basically using Foley catheter balloon tamponade for life-threatening bleeds of the neck. And I think this is pretty simple, is kind of like putting a Foley anywhere that's bleeding, but utilizing that the balloon tamponade effect of basically put it in a Foley. If it's bleeding, blow it up, and then get it imaged or get it to an appropriate center. And this might be something that's done in the field. It might be something that's done in wartime or other places by EMS or pre-hospital. I think this might be a little bit better in addition to just compression with gauze. This maybe is an additive.
No, it's fantastic. It merged out of South Africa, as so many amazing trauma techniques have. And there's not too much to it. I mean, Dave pretty much described it. Some things to keep in mind: you don't want a conduit of air into an area with an open vessel. So generally we'll clamp the back of the Foley so that there's no space. I'll flush it with saline first. And if it's a bigger wound, the idea is the Foley's actually blocking it off. But if the actual wound entry is a little bit larger, like maybe someone twisted the knife, you actually can put a purse string around the skin to just lock in the edge of the Foley. And it'll save your ass. And it's not just neck, anywhere on the body where there's a small entry but gushing blood. Sticking a Foley in it is a fantastic temporizing maneuver. So I love that you're reminding people of this tip. All right, now let's get back to the bread and butter emergency medicine. Someone has ripped off a nail, whether it be finger or I guess even toe, and you got a few tips on here. So obviously we should be sewing that nail back into the patient's nail bed, right, Dave? That's always fun to just try to bore through a hard and totally fungus-ridden nail with a suture. So tell us a better way.
It took me how many broken needles into some fibrotic fungal big toe of some 6-year-old guy with fungus in his toenail for some buddy of mine who's a plastic surgeon to say, "You're not still sewing back nails, are you?" Kind of like, you're not still investing with dad's wealth management guy, are you? And it was like a eureka moment where he said, "We don't do that. Just if you have the nail, implant it where it should be, like under the cuticle, and then just use a tissue adhesive to glue this on." And I'm like, "You can just do that?" He's like, "Yeah, because what happens when you throw in that suture is, one, you break the needle, or you put it into proximal so it doesn't go in exactly where you want. You replant, you digital localize, topicalize the area, whatever, do a metacarpal or some block, and then you shove it back in and then you glue it on." And this is great. I had a partner who was a runner and her nails would fall off. And this is a great thing to just have, to just glue back on. And you can even glue the matrix of the nail bed as well if it's injured as well. So I'm basically gluing the hell of the matrix, reattaching the nail. The only thing with this that you have to be cautious about is when they change the gauze or whatever like that, you got to be really careful that you don't pull off the nail. And I have seen patients who come back because it fell off. You just have to be really gentle because that's got to stick in place before new stuff. And this is just a temporary measure to prevent cuticle closure and new nail growth to come.
No, that's great. Now, technically, these tissue glues, you could go in the shower. Do you tell them to keep it dry anyway, just because it's such a tenuous thing, or do you let them go full on?
48 hours, keep it dry. Don't go for a swim in Lake Erie or anything like that after that. But certainly you're not banned from showering, but keep it dry or keep it covered for the first couple of days and don't overdo it with water pressure directly on the wound.
Good stuff. Now you have another tip on actually anesthetizing and then how to repair this. Tell us about that.
Yeah, this is actually personal because my wife was dealing with the typical terrible mandolin injury where she was kind of slicing and dicing some carrots and kind of chopping the carrots on the mandolin, shredding them. And then I heard that horrible sound of, "Oh my God, I just took off my nail." And as a doc, if it's not your partner, when you see these emerge, there's kind of this hint of relief because you know there's nothing to suture and you're like, whatever, this is great. I don't have to suture them and I don't have a resin with me. I'll just put a tube dressing and send them home, maybe a little Surgicel. And then I realized there's a better way of doing this. And it's really a stepwise approach. And the first step is you look at the wound and you're like, okay, they have a dime-sized divot on the tip of their finger where their mandolin got hit. And I just dunk their finger in some lidocaine, epinephrine, tetracaine, for about 5 minutes. So that's just anesthetizing, vasoconstricting the area. Then I pull it out. I take a tourniquet and wrap it on the proximal, let's say over the proximal phalanx. And then while that's kind of bloodletted and dry, I take a strip of a tissue adhesive and just seal off that wound. And this is what I did with my partner, was tourniquet it. I always have glue at home, and just do it. And it's great because, again, once you put some like tube dressing Surgicel, that person's coming back, and the second they take that dressing off, they're pulling off the whole wound and the epithelialized new portion together. So I love it. Let tourniquet, tissue adhesive, and then leave it, and you're golden.
No, this one was brilliant when I heard it, because I cook pretty extensively, so I've had the exact injuries that your wife has suffered as well. And they're a real pain in the ass because they bleed forever. And you hold direct pressure, and then as soon as you take it off, it just starts bleeding again. And tissue adhesive doesn't work at all because of the bleeding. But you found a way to actually be able to apply it in a blood-free field, and that's the game changer on this. Just as a culinary tip, if you want to avoid these injuries, the guards they give you with the mandolins are garbage. In fact, in the professional kitchens, they're just immediately chucked in the trash because they're virtually useless. They have Kevlar gloves that are the game changer. If you want to buy your wife a gift for never having this happen again, it's game changer, because you could actually hold the food in your hand, which is what you want, but you will not cut yourself anymore. So Kevlar gloves she's sold with every mandolin.
No, totally. And I think the last time we were shredding some carrots actually this week is there was like another inch full of carrot left because she wasn't going anywhere near the bottom.
That's another way to play.
It's
Absolutely
like,
right.
The hell with it. Potatoes, carrots. Like
carrots are
we're
cheap.
Just throwing
Fingers
away
are expensive.
An inch worth. Who cares?
Yep. All right. So shifting gears to a neurology situation. When you are trying to screen patients for Bell's palsy, it's sometimes a pain in the butt. And so you have a tip for that, Dave. Tell us.
Yeah, so we've always been taught with Bell's is the forehead affected. And that's kind of the way we have always said. And if the forehead is affected, you say, okay, it's a Bell's, whatever. Here's your steroids. I won't go anything beyond that. What there's no evidence for, but that's it. The problem is twofold. One, it's not so easy. And two, and I know where you're based, I know where I'm based, is we have a lot of people use Botox, and their foreheads, they basically can't even open their eyes at the best of time. So their forehead is not involved because it doesn't move. And I remember this was a great story, was I had this 26-year-old Botoxed up. Clearly, I thought they had Bell's. And I was sitting there and I was like, okay, I can see the eyelids weak, but I can't assess the forehead. And I was talking, I happened to be sitting beside a brilliant neurology resident. And I asked her, what do you do for these? And the first thing she said was, do you know how to examine cranial nerve 7? And I was like, oh shit, good thing I have residents. So they all knew the eye part.
Hey folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
And then she said, well, what else? And I'm like, oh, shit, let's see if the residents got this. I don't want to spoil it. Really, I was bluffing. I had no idea. And she said to me, it also affects the anterior 2/3 of the tongue. And the way you actually can test this, if you have a forehead that's not spared, is to get some sugar. So I think this is a great party trick, and a great way to confirm your Bell's is you basically, let's say you have a left-sided Bell's, you would put a little bit of sugar on the right anterior 2/3 of the tongue and tell the patient, can you taste that? Yeah, normal. Have them have a drink of water, and then put it on the affected side, and they will notice an appreciable difference. And using sugar and the anterior 2/3 to confirm the test of Bell's, whether it's a Botox Bell's or whether it is just a difficult Bell's or an incomplete or early Bell's, to me is a game changer, because then you can identify it's a peripheral cranial nerve 7 lesion and it's benign, and don't worry about it. Don't do a CTA or MRI.
Wonderful. Are you using D50 for this? Where are you getting your sugar weighed?
No, I mean, I usually go to the nurse's lounge and steal sugar, but all that stuff works. I just find sugar's easier, and it's a good field trip where you leave the merge and you get some sugar, whether that's in the calf or and something sweet's going to work.
I love it. We're like the Bell's capital of the world, Eastern Long Island.
Why? Why?
Just the tick population there is insane. Us and Lyme, Connecticut, we're right next to Connecticut. So we're the exact same geographical location.
Okay.
And it's horrible. I totally think it's bullshit, all of the textbooks saying that the lack of forehead sparing really is a beautiful determiner. We've had so many patients clearly diagnosed as Bell's, gone through the entire rigmarole of CTs and then Lyme testing, and the forehead thing is not perfectly consistent. So this is fantastic. This is something to have. Like when you see that patient, they're like 22, they have no vascular risk factors. Yeah. It's so clear they're Bell's, and yet, their 100%. Forehead is saying the opposite. This is what I'm doing now because this
I love it.
It's really good. All right. Now this one I also love. This one I kind of kick myself, Dave, for not knowing this. This seems like something I should have been given. The DKA one.
This is a you.
Yeah, but no, totally. I'm like sitting in your lecture with my mouth ajar because I'm like, that fucker. This is. I should have known this, but I didn't. So tell me about end-tidal CO2 as a screen, both to rule in and rule out DKA.
Yeah. So we always have the people who come in with high sugars, and there's the ones that look totally fine and they just have high sugars because for whatever reason their diabetes is not well controlled. And then you have the ones that are sick, and where you're going with this. It's going to be an HSS or a DKA. And I remember the sick the sick DKAs end up in rooms where there's monitors, right? They're not the person in ambulatory with a sugar that's elevated. So unfortunately, I'm going to go in PSI units with this one. You can convert in terms of stuff. But, I happened to see this person and the sugar was like 35 millimoles per liter. And I was like, wow, they look really sick. And we put them on the monitor. They were a little hypotensive, a little tachycardic. And I noticed their end-tidal CO2 was 5. And I said, the first thought in my mind was, that person's sick, that person's acidotic, and ordered a VBG. I ordered an AccuCheck. I got the sugar. 30 minutes later, I got the VBG, waited for the electrolytes, and started my DKA therapy. But then I thought someone must have also figured this out, and I came across this great study that looked at people with a blood sugar greater of 26 millimoles per liter. And what they said is if you look at that group, we're not talking euglycemic DKA. We're talking someone who has a relatively high sugar. If that person's end-tidal CO2 is greater than 35, you have ruled out DKA. And we're talking, you've ruled out DKA in 30 seconds because that end-tidal is going to pick it up the second you throw it in their nose. Now, if it's less than 21, their end-tidal, that is 100% accurate to rule in DKA. And if it's less than 26, that's 96% sensitive. So, when I saw 5, you can imagine this person's pH was terribly low and they were super sick. But it's just in the concept of doing things quickly in sick patients, you can make a diagnosis of a hyperglycemic DKA within 30 seconds if you use end-tidal and not wait for the VBG to come back.
Yep. Fantastic. All right, another super sick patient. You get a 22-year-old female come in and she's had hypotension, she has a little bit of abdominal pain, and you want to clinch that diagnosis of what's going on, but you're not going to wait for the quantitative, and she can't pee at that moment. What can you do, Dave?
Yeah, we both work in places where people don't have access to great prenatal care, or maybe they don't know they're pregnant. And exactly as you set this vignette up where you're like, this person's for sure a ruptured ectopic, their FAST is positive, I don't see anything in the uterus, I'm really worried about them. In the old days, we would send a beta to the lab for an hour. Sometimes we'd ask for a urine dip. Sometimes we'd put in a Foley. And then I learned this great pearl, which is if you're doing urine dips in your emergency department for qualitative testing, you can actually take a drop of blood and throw it on a urine beta HCG dipstick. And as long as their beta HCG is greater than 250, it will qualifiably tell you that that person's pregnant. So again, sick person, young, childbearing age, hypotensive shock, you need to rule out or rule in if they're pregnant. You will have an answer in 60 seconds utilizing blood. And everyone has blood. It's much harder to get it's much harder to get the lab to tell you, or it's much harder to get urine. Just use their own blood and drop it on the stick.
Yep, it's fantastic. All right, dosing of antibiotics. Now you're showing here in the picture cefadroxil.
In that, the picture I'm showing you is cefadroxil, which is a first-generation cephalosporin, which I had never heard of, which is available in Canada and may be available in the US. I don't know. Look that up. But what I will tell you is if you've ever been given a drug to take QID, like typically we dose cephalexin, which is 500 QID for a week, no one does it. I mean, Scott, I don't know if you've ever been prescribed a 4 times a day antibiotic, but
I have.
I remember I'm setting an alarm on my phone to ring every 4 hours or 6 hours because I'm not capable of taking it. So I think to simplify things, what I'm doing with cephalexin is doing a gram BID instead of 500 QID to improve compliance. And if you have cefadroxil,
I just checked. We do have it in the US too.
Yeah, everyone has it, but no one knows about it. And the ID nerds love it, especially in a non-compliant patient. It's 1 gram daily. Now, not every pharmacy outpatient has cefadroxil, but a lot of us in Canada have been writing a lot more cefadroxil because it's once daily first-gen cephalosporin that is amazing for compliance and has probably similar efficacy based on its bioavailability.
No, so much easier. I love that. All right, great. Okay, now we get to 2 tips on hyperemesis from cannabis. And tell us.
Yeah, I mean, patients who come in with scromiting, the worst chief complaint, screaming plus vomiting. Unfortunately, you got to help these people out. The answer is not opioids. Despite, and what I find most interesting about cannabinoid hyperemesis is this denial of why they will not admit that it's the cannabis, but that is a whole other lecture in itself. I think the key here is typically we're using Reglan, metoclopramide, whatever you have. We're using ondansetron. I think now we are using haloperidol, or probably in the States a lot of droperidol as first line, and I'm using 0.05 milligrams per kilo IV. If I've already given them a bunch of antiemetics before, I'm probably doing an EKG just to check their QRQT, stuff like that, which makes sense. But I've found that haloperidol has been a game changer. I tell people this will help with their pain and their vomiting and nausea, and it really does. And it's not because they're crazy, it's because it works. Mm-hmm. It really does.
Are you using this routinely? That's all I want. That's
the screaming stop is really challenging, but if there's an element of psychosis with it, I could see how the haloperidol will help.
Yes, it can't hurt. And yeah, you're absolutely right. It affects the nausea, it affects the pain. It's maybe the perfect drug. You've found the antidote to this clinical scenario. Tell us about the capsaicin cream.
Yeah, so really where we've always detected these people is they come in and they say the only thing that works better is a hot shower, right? They have high heating bills, high water bills because it's a hot shower. And that ain't working. That's expensive. One of the options is using capsaicin cream, which is just a hot pepper. And you basically smear, for lack of a better word, onto their anterior chest or on their back. And you tell them to do it. They can wear those gloves, not the gloves from the mandolin injury, but some other gloves, and just put it over their belly. And that will generate substance P, which is something that raises heat and kind of without bankrupting their water bill will give them some relief. So I'm telling them on the way out, you might want to get some capsaicin cream. Here are some addictions resources because it is an addiction, and this will help temporize things because the haloperidol is not going to work forever.
Absolutely. No, you've given them the ability to live their life without having to be in the shower constantly. So that's fantastic. Trigeminal neuralgia sucks. It is, having seen the poor patients dealing with this, it is just horrible. So what do you have as a tip for that, Dave?
Yeah, so we're a real center that has a Gamma Knife and a neuro center, and we see a lot of these patients who go for surgical treatment. So in trigeminal neuralgia, when they have seen their primary care practitioner, their neurologist, and they've been put on a slew of drugs like pregabalin, carbamazepine, they've tried things, it's not working. What I will use is phenytoin. And actually, phenytoin is a fantastic drug for this population if given IV. Now, I don't give it at the status epilepticus 20 per kilo dose. It's a lower dose and goes slow, 10 milligrams per kilo. So you might give 700 milligrams of IV over an hour. I find it works extremely well. Like any time when you're using phenytoin, there's always the risk that they go hypotensive or they're just not steady on their feet after, in which case you can refer that to another service if worse comes to worse. But I do find that patients will be so appreciative. The challenge is it's not a long-term fix, but it's certainly a fix to get them out of your emergency department with a little bit more hope and break that pain cycle. It's not a definitive treatment, but I can tell you a lot of us have started using it, and it's been great. And I'm not using it as first line. I'm using it in the people who like their life sucks because they've tried everything and nothing works.
Any reason we can't use fosphenytoin, Dave?
I can't think about why not. I think it would be the same thing, just faster.
Right,
so of course.
Okay. Now another miserable situation. We're talking about gout, the punishment for good living.
Cruel.
Yeah.
Yes. I mean, so gout. I mean, I feel like we don't really treat gout well. We usually prescribe some anti-inflammatory that probably has no more evidence than ibuprofen, and we feel good about ourselves. I think it's a missed opportunity to treat early presenters in the emerge or treat patients with a pill in the pocket at home. And what I'm talking about is a trial that was called the EMCrit trial that looked at acute gout. So people who have, let's say, a podagra, known gout or not known gout, their first toe or some other joint, it's definitely gout, flares up within 12 hours. And usually on the first presentation, that might not be them, but it may be. So if someone comes in with 12 hours, what I am doing is giving 2 tablets oral of colchicine. So in Canada, and I think America, it's supplied as 0.6 milligrams. So I give 1.2 milligram pill, and then an hour later, I give them 0.6 milligrams. So they're basically getting a 1.8 milligram dose of colchicine over an hour. We're not going to ridiculous heights. The old days when you and I trained Scott, it was like, keep using colchicine until you have the shits. We're certainly not doing that using diarrhea as an endpoint. We're going at a safe, reasonable dose. And then what I'm doing to patients is I'm saying if we have success with this, or let's say they miss the boat, is if this happens again, here are 6 tablets of colchicine, 0.6 milligrams. This is what I would do. And patients will then have that pill in a pocket approach where they don't need to come to a hospital. I feel my toe coming on. I'm going to take 2 tablets and then an hour later, 1 more, and then I'm done. And then you buffer that with your NSAID if you need additional pain support.
That's great. All right. Iron. We know patients need it if they're anemic and they're iron deficient. We don't generally tell them the right way to actually take it. So tell us, Dave. Educate us.
Yeah, I think there's a whole cohort of young women who are iron deficient and cognitively impacted by this. And I think they've all gone through this cohort of dysfunctional uterine bleeding who has a low ferritin, maybe a normal iron, maybe not, or a hemoglobin rather, and they're on some whopping dose of iron that basically makes them have diarrhea or constipation or nausea or vomiting. They don't want it. So it leads to noncompliance. And a couple of the great hematologists, Jeannie Callum, Yulia Lind, kind of taught a whole bunch of emergency doctors how to replace that, which is basically saying that you give too much iron, you will impair the ability of them to absorb it. So what you want is about 60 milligrams of elemental iron. In Canada and the US, we use ferrous sulfate, which is 300 milligrams at 20%, which is 60 milligrams. And the way you actually have to spend time with people, and you'll realize that no one has ever been told how to take it, is you're gonna take 1 tablet, 300 milligrams. You have to be fasted greater than 2 hours, so it's on an empty stomach, so typically on bedtime. And you're gonna take vitamin C with it, so 500 milligrams. And if you give too much, you basically raise your hepcidin levels and you decrease absorption. So you don't want any more. And in fact, if this is intolerable to the patient, I will say use it every other day. So if you find every day is not working for you, take your 300 tablet with 500 vitamin C at bedtime. And if every day sucks, do it Monday, Wednesday, Friday. And that is the way to coach them back to levels.
Very reasonable. Do you give them a bowel regimen for the induced constipation from it?
I haven't. What do you think?
I don't know. This is this is luckily not my profession anymore. I excise myself from general emergency medicine, so IV iron is the only type I'd be given. But,
yeah. So different kettle of fish, right? Those people who come in 56 and you want to give them some Venofer, I get it. This is someone who you just want to get them feeling better. They don't need IV iron. Yeah, I'm sure I could coach them through constipation or definitely give them resources as to who to talk to help them with.
Now, Dave, I left this one out, but you wanted it back in. So you insisted we put in the nasopharyngeal airway to facilitate placement of an NG tube. Tell us about this.
Yeah, so this is a Simon Carley pearl, and again, it fits with the theme of I hate shoving shit in people's nostrils. And I also know that I don't put in an NG tube, and I'm not here to discuss the merits of NG tube insertions for bowel obstructions. But you and I both know that we call a surgeon, there's a bowel obstruction. The first thing they're going to say is, okay, put an NG tube, we'll come down, we're just in the OR, we're scrubbed. Or the other thing, you have some patient who is an overdose and you intubate them, they're sick, they're in ICU level care, you're gonna have to put something down, an NG tube, you just throw in the tube. And I'm not that skilled. One, because I don't do a ton of NG tubes. Two, you do them and sometimes you can't get them in the right pathway and they start coiling in the mouth and you're like, oh my God. And Simon taught me this amazing pearl. And again, this is not an evidence-based talk, but this actually has evidence, which is if I say to you, Scott, you know what, just throw in an NG tube, you fire in that NG tube and you do it blind, you basically shove it down the nostril. You're basically flipping a coin if you look at this, about 47% first pass success. But if you use a right nasopharyngeal airway, so it's kind of like a Seldinger technique where you put in a right nasopharyngeal airway and that then you put in the NG tube through that kind of guide wire, that nasopharyngeal airway, you have bumped your nasogastric tube success to 83%. So 83% versus 47 is a 36% absolute risk reduction of a bad outcome. You're looking at a number needed to treat of 3. So I can tell you the last person I tubed, of course they were asleep, so that was the person perfect to try it on. I just shoved in the NG tube myself and it was bliss. Because it took a second and I knew it was in the right space and it wasn't coiling. And I think this is a great way to do it. It's not going to be more unpleasant to the patient. It's going to be dramatically more pleasant because it's going to reduce the number of temps and it's going to go in.
Now, I'm putting on my intensivist hat here. If you're doing this trick for patients that are going to have that NG tube in for a while, I kind of don't like having a nasopharyngeal airway around it. It markedly increases the outside diameter of what's stuck in the nose, and I think predisposes patients to sinusitis. And for patients like that, for all my patients really, but for patients like that especially, I'm going to be placing a Salem sump. They're already a wider diameter. What I will tell you is this: if you're going to use this trick, then do one of two things. Either pull the nasopharyngeal airway out so it's sitting outside the patient's nose, and then it could just sit there, resting on the outside portion of the Salem sump. Won't cause any problem. That's fine. Or you could cut it once it's outside the patient and just try to get in there. But there's a high likelihood you're going to cut the NG tube, so you probably don't want to do that. So the real win, the way I would do this if it's for anyone, this is the way I'd do it, is I would slit that nasopharyngeal airway before you even put it in the nostril. And then what you do is, after the Salem sump is in, withdraw the nasopharyngeal airway, and then you could just strip it off the NG tube. And this is the same thing I do with endotracheal tubes to place esophageal probes down. So this is the great way to do it and not have to leave that nasopharyngeal airway in. Okay, I love it. All right, we are finishing off on one that is the Jedi mind trick of this whole tips and tricks session. You have a consultant who you clearly know what the patient needs, but the consultant's having none of it. They're just blowing you off. What do you do, Dave?
Yeah, so this is a trick. This is something I learned in my residency, and we all have these difficult conversations. And unfortunately, the nature of our profession is we refer patients. We're not an accepting service, we're a referring service. And we all know that at 3 a.m, sometimes it can be difficult, but our job is to be advocates and to push for patient care. And I would say that of every trick and trade that I've just given you, this one's really important. It's something you don't want to use it every day. And it's something that some people might need more than others at different points in your career. But it's the memorization of the following phrase. So you have a patient, you are worried about a dissection, it's 3 a.m, you're working at a small hospital, they don't have a tech, they have to call someone in, you're getting a lot of pushback from whoever that is, and you say the following statement. I am sure you can understand the implications of both of us missing this diagnosis. You then pause, because there will be silence, and you repeat, I am sure you can understand the implications of both of us missing the diagnosis. We need to do the CTA now. 100% success. You are guaranteed to get the test you want. No one can say no to that.
It's the perfect place to stop, David. This has been fantastic. This has been jam-packed. This is clinically utile on your next shift. David Carr, I can't thank you enough. I understand why the Europeans love you, and I love you as well. Thank you for coming on the show.
Love you too, pal. Always fantastic to chat.
As always, promote dignity, relief, and warmth. Very rapidly, some current projects you may be interested in. The Awake and Aware Conference, Scottsdale, Arizona, February 2027. Its Kickstarter has sold out, so the conference is live. Unfortunately, you missed the super discounted tickets, but the full price tickets are now available, and I will tell you the link at the end of this discussion. But that conference was amazing last year. It will be amazing this year. The Out on Time course, it is our charting course, our malpractice avoidance course, our getting out on time course, feeling on top of your shift efficiency. The spin class, that is our vertigo and dizziness mastery class. It is to get you to the point where you will be eager rather than dreading picking up a dizziness chart. We have the Resus Leadership Academy. That is our online fellowship to take you from emergency medicine or hospitalist to aggressively potent resuscitation doctor. You will be the person in your department leading the game on resuscitation and acute critical care. The Unburnable course, that is our burnout prevention course, our finding joy and flourishing in your career course. That is a cohort online course, so it is done in real time, and it has been lovely. This is our 5th cohort. And then, last but not least, the Reanimate course. That is our eCPR, ECMO CPR, and resuscitative ECMO course. It sells out every year. If you want to come, the time to buy tickets is now, because every year I get people, 4 months before the conference, they're like, I really want to come. Well, guess what? You can't, because I told you for the 5 months before now that they sell out every single year. You should have listened. So if you want to check out any of that stuff, come to EMCrit.org/stuff. EMCrit.org/stuff. That's EMCrit.org/STUFF. So I've loved talking to you. I'll talk to you again soon. Scott Weingart saying bye-bye.